Hi, everybody. I'm Laurie Solomon, Chair of the Health Roundtable. And first of all, I'd like to welcome a recent member to the League, Tanya Martin, who I've had the pleasure of meeting in person in February. I would also like to welcome our guests who share our interest in the League's healthcare goals. While I was away last month, Rob was busy putting together today's program. So
prior authorization, utilization review to screen claims. Traditional Medicare operates a little differently. It is a nationwide network. 95% or more of the doctors in the United States are members of traditional Medicare. Enrollees in traditional Medicare will often purchase on their own a Part D and a supplemental plan, as I mentioned previously. All right, last slide, and I'll stop and turn it over to Kim and Bridgette. Jane? So some issues that you may not be aware of, but hugely affect these two plan designs. One is adverse selection. That's an insurance term. Adverse selection simply means that unhealthy people with chronic diseases, will gravitate or choose the richest plan or the one that offers the most choice. In this case, they're going to gravitate automatically to traditional Medicare because of the open network. And you can even see in the statistics, because yearly you have a chance to change from Advantage to traditional and traditional to Advantage. When people have health issues, they tend to move toward the traditional Medicare, which has an open network. Issue number two is administrative costs. And I'm saying this partly from what I've read, partly from my own experience as a health insurance broker. Administrative cost is less for traditional Medicare. It's somewhere in the range of 2 to 5%. Commercial insurance is in the range of 15 to 20%. And it's an open issue as to whether the managed care portion makes up for that difference in higher administrative costs. And then two other things. One, in the news lately have been a lot of articles about upcoding. Upcoding is another insurance term. It means, are the hospitals and doctors adding additional codes to diagnosis to leverage their payments? And that's been a pretty widespread accusation with the Advantage plans. Although I have seen it also in traditional Medicare, because many of these medical practices have consultants who come in and advise the practices how they can code to bring in additional reimbursement. And then on top of all this is this huge question that is ongoing. Is healthcare and our corporate profits compatible, or can they be used to the advantage of the client? And that's a topic Kim and Bridgette will talk to us about, and I'll stop at this point. And I don't know which of you wants to go first, but one of you begin.
I default to Bridgette because she has a lot to offer for education on her realm of Medicare Advantage, and then I'll work off of that if that's okay, Bridgette.
Absolutely. And I apologize, my screen went black. If it goes black again, the room I'm sitting in, apparently the light is on a motion sensor, so I need to move a little bit. Yes, so I can speak at least to a couple of those points. So just my background a little bit. I started as an emergency room nurse. What prompted me to go back to school was seeing the patients that were coming into the emergency department and using the emergency department essentially as their primary care and as their safety net. And they either were there for primary care needs or they were there for acute conditions that should have never gotten to that point had they had the proper preventative medicine and the access to care. I did work for a small community nonprofit, what we would consider a safety net hospital, for the majority of my nursing career. And so that was probably the majority of our patient population. So I felt like if I could get ahead of it, then that was how I could help make a dent in that problem. So I did go back and became a nurse practitioner, and I started working in private practice first. That wasn't necessarily my intent, but that was where I ended up, and was grateful that I did. And it was a great experience being in a private practice where I did have a little bit of a hand in the billing and the contracting. and, working for a larger organization that kind of contracts out all of their billing, you don't get that as a provider, but I did get to see that. So I have seen it from the fee-for-service world, where I've had to be on the end of prior authorizations with particularly commercial and Medicare Advantage programs. And I can say firsthand how frustrating it is as a provider to speak to an orthopedic surgeon as a cardiology NP why my patient needs this particular cardiac test that there's clearly an indication for, and we've clearly met all the appropriate use criteria for, and I'm still having to take time out of my day to go through this conversation. Then certain personal and professional things led me to the Medicare Advantage world, where I never thought I would end up. And all of my time in Medicare Advantage has been spent in special needs plans. So that is where I can speak the most clearly to. And my personal belief is that they do answer a lot of the concerns with Medicare Advantage plans. We are able to tailor our supplemental benefits and our offerings much more to the population we serve, because it is a special needs plan, which means that it serves a very unique population. And if you're not, I don't know, the familiarity with special needs plans, but right now there are 4. There's the chronic conditions. I believe that was actually the first special needs plan to be developed around 06, I believe. And then there is DSNP, which is dual eligible. So that's anyone who's eligible for Medicaid and Medicare is eligible for those special needs plans if they're offered in their area. And then there's ISNP and IESNP, which are very similar. It's institutional special needs, and then institutional equivalent, which is Medicare recipients that meet the criteria to be in a long-term care setting, but for whatever reason, they live in the community or in an assisted living facility instead. So those are the special needs plans. I don't know how much you want me to speak to each of these. I can speak to the upcoding, since that's certainly on everybody's radar right now, because Medicare has announced that they will be doing some pretty significant auditing and coming after a lot of those payments and what they deem as overpayments. I believe that process should be simplified. If you are familiar with the risk-adjusted processing and the diagnosis codes that Medicare increases payment for, it consumes a large portion of our time as providers that work for Medicare Advantage plans. It's hard for me to speak to hospitals and private practices as far as their upcoding. I can say we are under so much scrutiny between, I think, the DOJ and the OIG and CMS, that our coders, we have a coding team in place to ensure that we're not upcoding. I will say that our charts are audited. We do have those internal checks and balances, and I've worked for 2 different Medicare Advantage companies that both had those checks and balances in place. So to speak to how much upcoding is an intentional problem, I don't know that I have a high degree of certainty in that. Whether it's unintentional, though, I can certainly see where there could be issues with upcoding unintentionally. Is there more you wanted me to speak to, Rob, on?
Well, we'll move on, let Kim talk, and I will make a note again, for those that are not familiar with Zoom, there is a toolbar at the bottom, and one of the icons is chat. You can click on chat. We already have one person that's, Margaret has put in an article that she'd like people to look at. But if other people have questions, enter it under chat, and we'll stop and answer those questions. So Bridgette, stopping point for you. Kim, are you ready to talk, Kim?
Yeah, sure. Always. I would just say, taking a step back, and I appreciated your differentiation, Rob, in the intro, is, it's different as a provider in every setting, how billing works. And I have taken care of patients in community clinics. I have taken care of patients in the state hospital at UNC at Duke, which is a different sort of setup. And then also in clinics PDC clinics in Durham, and then also in the home through the Medicare Advantage sort of dual eligible patients, and then also in these long-term care facility under the ISNP plans. And what I'll tell you is, as a hospital provider, you really don't see the billing side of things other than having diagnosis codes for every patient that comes in and whether they're resolved or continue. And then they have billing people do that. So there was a lot that I didn't know was happening as a provider in the hospital. Where it came to hit you over the head was when you would discharge a patient. And it didn't matter whether it was a Blue Cross Blue Shield plan, Medicare, whatever. At discharge, you'd had the medication. This medication is the ideal one to go home on. And sometimes it was a second line, third line option. And it became a real, as we used to say, like hot mess to try to get somebody home where their discharge could be delayed by 3 days to a week based on approval for an antifungal that had to be prescribed. That is a top tier or not as commonly used. And I talked to 3 different people and get a pharmacist involved to get the approval for this, so this patient doesn't get some invasive fungal infection in their lung, okay? And you have to justify, and it did not matter if it was Blue Cross, Medicare, what have you. There's always a fight on the end side from the inpatient side if it's a very complicated patient typically, and you're discharging home. That's where I would see the frustration. And honestly, I can't say one thing stood out from another as hitting those brick walls. It is just something we come across no matter what. Sometimes those, it tended to be more difficult to get the things needed for those patients with those plans because of the amount of people you have to talk to get it versus a case manager getting involved for a program to give it to a Medicaid patient or something like that. So there was a lot of variability there. When we were in the, when I was doing clinic work, there was more billing. You tied to the billing. And you also tied to the level of care you're giving in that setting. So how much time did you spend with the patient? How much, what did you do? How many systems did you address during this meeting with the patient? And that goes to a utilization manager too, where people are in charge of whether you're billing appropriately or not. What I will say is that you do think more about that just based on being told they can't have this prescription because you didn't try this, or this first. And again, can't tell you what was better versus what was not in that setting. A lot of these are insurance, what did you call it? We'll say traditional insurance, a Blue Cross Blue Shield, a Medicare plan, whatever. When I got to outside of the big institutions and we got into these home-based Medicare Advantage plans, what I noticed was you diagnosed patients based on their current illness. And a lot of these patients that I saw in the first company that I worked with were long-term chronically ill, at risk for a tipping event, which may be easing into a terminal situation. So the average patient that we took care of in my Prospera, which was the Medicare Advantage plan, was somebody who was considered by their diagnosis before we took over as their healthcare provider for Medicare Advantage. They were considered in the risk of being terminally ill, passing within 3 years because they were had an advanced chronic illness. So you would diagnose them, you would assess them, and you had what I like to call core measures. That's a term that comes from the bigger institutions, where if CMS was paying, you had to address every system and tell on paper how advanced their illness was. COPD, heart failure, renal failure. Do they have all of it, some of it mild? What is your assessment of this patient? And that gave an idea of what their need was going to be over the next year. So you have to put in what you see that day, and based on the billing or based how these plans work, then they get let's say a bucket of money for every patient, and you want to assess them honestly in that moment. But as a healthcare provider, I can tell you, you can have stage 2 renal failure, but do I know when you're going to tip over to end stage? No, I don't. So, you just our role was to see what this person looked like today. Do I see a new diagnosis? Has anything changed? And then it's I guess, a best guess for what happens over the next year. And so it's a tricky thing to try to think about in terms of finances, because it wasn't something that was on my radar. I just saw that patient that day. This is what they look like. Yes, they have heart failure. Yes, they have stage 2 renal disease. Yes, they might have diabetes. It's well controlled today. But what that looks like 12 months later or 11 months later, you don't know. How many hospitalizations are ahead for this patient? Because no matter how well you take care of a chronically ill patient, if they're in the end stages of that chronic illness, there will be events that cause you to have a hospitalization and require more focused maintenance and frequent visits to your cardiologist or your nephrologist or your endocrinologist. So I think it's very hard to really determine what that looks like for each patient, but you just do the best you can with the knowledge you have. Now, moving on to the long-term care, I think these patients with Medicare Advantage, what I loved having been a provider was that these patients had a cadence to their healthcare providers. All I saw as a provider who took care of patients in an ICU who may not have gotten what they needed in a long-term care facility and ended up in a critical event in the hospital that could have been prevented was, wow, this program offers an NP in-house every week to assess the higher risk patients once a week, the not as high risk every 2 weeks, and the really stable, not likely to really have a tipping event as easily every month. You don't get that in every other program. And I thought that was fantastic, because you can really see when you see a patient who's got multitude of comorbidities, you can see them every week and start to see those changes subtly when you're trained, and then maybe really prevent a hospitalization that was not necessary. And I think that's the takeaway to what these plans like Bridgette is managing offers. And it comes down to healthcare literacy. I think that's the best way to put it. I think the choice of Medicare is fantastic. You can be anywhere. Everybody understands Medicare for the most part. I mean, on paper, it's somewhere you can find. And you have a lot of choice, but do you have healthcare literacy to be able to navigate it and know when you need to be seen? Because I guarantee you, the very busy cardiologists, nephrologists, and all of the specialties aren't going to know when you gain 5 pounds in a week and need to be seen as soon as possible before things get out of control. Because at some point, that end stage chronic illness will have a tipping event. And sometimes it's subtle and only a trained eye will see it. Or a sister, brother, daughter, son who's a nurse might be able to see it and call your cardiologist. But you have to have, I think these plans it's not a one size fits all. It's what's best for the patient. And if you've got somebody who can't speak in a long-term care facility, Medicare is great if you have somebody there making sure you're noticing the differences and the changes when they need to be seen. But Medicare Advantage, to me, in that particular patient that may not have an advocate or somebody very literate with the healthcare system or their particular diagnoses, you have now an MP who can be there to check on them every week and see a problem and see the forest through the trees before we have a crashing and burning patient that needs to go to the local ED. And so I think it really does depend. It's not one size fits all. And it's an individual choice, obviously, that it should be based on more than one thing. And I think that's my stance, as just from my experience. And I hope that's helpful. And please ask questions if that was confusing.
Yeah, we have one question in the chat, and I will get to that. I'm going to pose a question, Bridgette, to you and then to Kim. Same question. Let's assume that you have an older relative, perhaps a father-in-law. Would you be comfortable putting him in a Medicare Advantage plan?
Yes. I do believe that there is a level of advocacy and care coordination that comes with most Medicare Advantage plans, if nothing else, because we're responsible to Medicare for such a high degree of metrics that we have to have that level of advocacy and that care coordination to ensure that you're following up Yeah, I mean, I do. I have two grandparents that my grandfather's pretty chronically ill. My grandmother's very healthy. But yes, I would recommend, and they both are in Medicare Advantage plans, that they would be in Medicare Advantage plans.
And Bridgette, can you explain the metrics? Because I think that's really important for people to understand. Like it doesn't matter where you are. These metrics are universal typically across the CMS spectrum. But like, can you give an example of like your metrics that are just, I think that's helpful.
Yeah, so we have, there's two different categories. There's STAR and there's HEDIS metrics, and I could get in the weeds of explaining which go into which. But some of them are just ensuring that we're doing the proper assessments. So we have to make sure we've done a functional assessment at least once a year on our members so that we can document if there's a change in their functional status. But then others are more clinical based, that we have to document that we are, not only are we monitoring their hemoglobin A1C to check the status of their diabetes, but that it's controlled. Same with kidney function. We have to document that not only are we checking for a decline in their kidney function, but if we note it, that we are treating it. If we have anyone that has a diagnosis of diabetes and they're being actively treated for their diabetes, are they also on a statin for the cardiovascular primary or secondary or maybe even tertiary prevention? And we are held as a plan to all of these standards and our own STAR rating. And you don't stay in existence very long as a Medicare Advantage plan if your STAR ratings are less than 4. So again, if nothing else, that's causing us, or it gives us a reason or a motivation to advocate for our members. But also because of the way the payment model is, we are receiving this money from Medicare, and whether we argue it's too much or too little, it is what we get to take care of our members. So it is in our best interest to take care of our members in the most cost-effective way, and preventative medicine will always be the most cost-effective way to take care of anybody. It doesn't matter how old you are. It's the best thing for my kids to get, physicals and vaccinations than to treat them for flu and pneumonia or asthma or anything else. So it is in our best interest to provide the staff, and it's different for each Medicare Advantage plan depending on the population you serve, whether that staff are social workers or nurse practitioners or nurses, to make sure that we are essentially going after the members we serve to provide this preventative care to prevent these costly hospitalizations. So to answer your question, Rob, that circles back to that. Does healthcare and corporations mix? This is where it does, because this is where, even if it is a financial interest in saving money, it also coincides with better health outcomes. We know it is better to treat patients. Sorry, I told you I'm in this room with the motion sensor. It's better to treat them outpatient. It's better to treat them in their homes, in the nursing homes and the assisted livings, than it is in the hospital. Yes, that saves us money as a Medicare Advantage plan, but it's also what's best for the member. So those things are not necessarily mutually exclusive.
And I'll jump in and just say, in my experience, never was there a deterrent when I felt like I needed my patient to go to the hospital. Was there a second or any pushback to get them there or get them to the specialist? And I never had a patient denied for a consult or a specialty referral. And it was in my experience. I only worked with 2 companies. But the last one was definitely a more significantly chronic and complicated population needing long-term care and skilled nursing. Never did I have an issue on waiting for approvals. One time we had an issue finding a derm clinic close enough in the town because it was in Eastern North Carolina. But we found one and it was able to get transport. And so I didn't really have a problem. And I also thought a benefit was some of the dentists and the ophthalmologists would come to the facility as part of this plan, which was fantastic. Because it's very difficult to get somebody who can't walk transported to a clinic setting where they run late or run ahead or have to cancel. And, there's a lot involved with getting a patient who is immobile or unable to get themselves to places to have these services come in. So I thought, I didn't have any issues with obstructing care in any way, shape, or form, or limiting the care.
Kim, I want to just make sure I'm clarifying. I think what I heard you say, that a lot of your frustration came with the prior authorization of prescription drugs. Is that correct?
For in the hospital setting. Yep, in the hospital setting. That was really the only place when patients were as sick as they were in the population that I took care of, you tended to just order and get what you needed. Where we'd hit brick walls tended to be on discharge with certain medications. And the more complex the patient, sometimes the more maybe they failed a treatment plan and you need something additional, or they're extremely immunocompromised. So they need a very special, expensive antifungal because you can get all kinds of crazy infections from everything you see every day when you have no immune system. So I would have to fight a variation of versions of people and have a discussion with a pharmacist for the insurance company over why we chose this particular medication. That was my frustration from the hospital setting. And that did not matter what their insurance plan was. It typically was a private insurance plan.
Kim, do you know, and I'm not clear either, whether those prescriptions would have been covered under the Plan D, or were they more injectable kinds of things that were covered under the hospitalization?
If it was to go home, it probably was more of a by mouth medication, but I don't know. There was a lot, like I said, when you're in that hospital setting, in the acute care setting, critical care, you don't see a lot of the financial aspect of it. You just kind of put out fires and deal with what
and my experience, just to tell you from having dealt with thousands of claims, is most doctors don't have a clue what the charge is. A lot of that is generated from the business office or a consultant who comes in.
Yeah.
I've called on things like colonoscopy saying, why is this coded like this? And the doctor said, well, I don't care. Just how should it be coded?
Right. Well, there's a lot of different codes, and it gets more complicated. It feels like every time the ICDs are changed and everything. But I think at the end of the day, a lot of times we are supposed to work with guidelines. What is the standard? We want to do the minimum standard of care and obviously do better than that. And so as providers, we look at what are the latest guidelines? What's the best first choice for this situation? What's the next best choice if this first choice didn't work? And you have to look at those standards and guidelines, and typically you want to practice that way. And this other stuff comes into play later. And a lot of times, and I feel like in the clinic setting especially, the patients will tell you, oh, I couldn't get it. What else can I do? I can't afford this, or it's cost me this much, or it was denied. And then, you look for resources. That's where case managers and social workers, mostly case managers, really help find resources and discounts and coupons. And, it's just very complicated. And I don't really, as a provider, see that much of a difference. There's no plan that stands out, and each one has a pro and con, many, and there's nothing that stands out in my mind as one being more problematic than the other. I feel like Medicare is pretty standardized. So the hospital billing system or people in charge of that tend to get to know what Medicare is going to cover and what it's not. So that's a little easier to reference when you're in that setting. But it really is just extremely complicated and multifaceted and dynamic. And I think that I just don't know how to answer your question with the parties. So
okay, well, I'm going to go into the chat at this point and ask these two questions. The first one I'll try to answer on my own based on insurance experience. The second one, Bridgette, I'll throw open to you and Kim. So put your seatbelt on. The question was, I have a Medicare Advantage plan, which is a limited network. What will happen if I travel outside the area? And I happen to know a little bit. I'm not licensed. I'm not a Medicare expert, but I know a little bit about this particular plan. And it does have out-of-network benefits, which means you would be covered outside of network, but you would pay more for copays and you would pay more for your out-of-pocket because you're outside the immediate network. Now, also, I will tell you that with any of these limited network plans, federal law requires that if something is an emergency, it has to be treated like it's in network. The issue comes up is, what is an emergency? I mean, if you've got a runny nose, that's clearly not an emergency. You're going to have to wait till you get home. If you break a leg, that is an emergency. So anyway, I don't know if that answers the question, but that's my shot at it. The second question, which I'm going to read to you, Bridgette and Kim, is though medical advantage plans may be best for high-risk patients, is this the model that you think is best for the majority of Medicare patients? The former should have more money spent proactively on their, I think, care, but the healthier majority may not benefit from additional services that we're paying for. And I think that probably referenced some of the things like dental, vision. And I will add here is, and again, I'm speaking from experience, most of the advantage claims, not claims, but complaints or grievances that have been filed are generated by the dental coverage. The dental coverage is crazy on Medicare, and it generates an awful lot of grievances, insurance department complaints. So anyway, Kim or Bridgette, why don't you go first in terms of the question about this? Is this the best plan for the majority of patients? It may be the best plan for high-risk patients. So here you go.
All right. Well, first, I won't speak, and I probably should have looked up some numbers on what the actual majority is and what the, if we're talking about a Medicare population, if we're going based on age only, because that is noteworthy that at least in our Medicare Advantage plan, about 20% of our population is younger than 65. So yes, they're clearly high risk because some other disability made them eligible for Medicare. But this is where I still think it makes the conversation on a universal model of care extremely difficult, because there is not a one size fits all. And so it may be that traditional Medicare, if you're not really using it as much, is a better option because it's cheaper up front. But I would also have to make the argument about correlation and causation. If you have reached the age of 65 and you are low risk and you do not have significant medical problems, there more than likely is a financial aspect that allowed you to live for 65 years with a diet and with the activity and with the resources that kept you healthy. So that is where too, I would argue that Medicare Advantage plans often tend to be more beneficial for those who have restricted access to care, which then also leads to poorer health outcomes and makes them high risk. So I don't have an answer for that. I do know they are cheaper. Again, in the population I serve, most of them are dual eligible, which means they have Medicaid as well. So cost isn't actually an issue in the greater population that I do serve because Medicaid is paying the premiums. I don't have a solid answer, to be honest with you. I think, like I said, this is what makes the conversation extremely difficult about a universal model, because it's not one size fits all. And it does get very complicated when you reach a certain age population and the disparities in their health condition is so varied and their needs are so varied.
Yeah.
Kim, before you answer, I'm going to ask a question to the group. And if you darken your screen, use the reaction button at the bottom of the toolbar. And if you don't have to answer this if you don't want to, but I'm just curious from our segment of people here, if you're a Medicare eligible person, put your hand up if you're enrolled in an Advantage plan. Looks like a majority are in either not enrolled in Medicare. And Kim, I know you and Bridgette are not enrolled in Medicare, thank you. But anyway, so it looks like a majority would be in traditional Medicare, which is interesting. Kim, I'm sorry to interrupt. Go ahead.
No, that's fine. I think I'm going to just say it again. It's not one size fits all. I think there's a lot of variables. Again, this is my perspective as a healthcare provider in the spectrum of settings. It really depends. If you have, I think you have to think of it in terms of healthcare literacy. In my opinion, those with healthcare literacy, meaning they understand how to navigate the system, they understand their own health issues, they understand what that looks like, what to look out for when things are changing so that you can get that intervention, that prevention before things get out of control or get worse, which with many diseases will eventually happen. It's just as how long you don't know, but you do know what can exacerbate a problem or get worse if you are literate in your own health issues. If you're not, do you have somebody next to you, your husband, wife, spouse, partner, child, nephew, niece? Is there somebody, your neighbor, who has a trained eye that can see that sort of change or help you guide through that and get you to the appointments, get you to all the various choices you have if you have Medicare? Then that might be the best route because you have more choice, but you also know how to navigate the system and get what you need, because you can have Medicare all day long, but if you don't know when to ask for help and you're just going to follow the every 3 months or once a year or once every 6 months you see your specialist, well, if your disease is out of control, is it really helpful? And if they make you wait 6 weeks to get an appointment for your 10-pound weight gain with your heart failure, that now your meds that have been working for 3 years aren't working anymore, are you going to end up in the hospital before you go see that cardiologist? Versus, same example, in a facility, because you can barely speak coherently because you have aphasia from your last stroke and you are bedbound and also have heart failure, that weight gain will be seen by a trained professional, maybe not the nursing assistant that sees you every day, or maybe not getting weighed every day, but that NP that's assigned to you weekly will see the changes in your feet and see that your edema is getting worse and get you seen sooner than later, or seen within 3 days, seen today. Also increase your Lasix before we even get you the appointment. You know, if you're looking at it in terms of that, which one is better? You know, these facilities are supposed to have trained professionals that will note these differences immediately, but does that happen every time? No, but if you have that added effect of a Medicare Advantage provider looking at you at a cadence once a week or once a month, depending on your diagnosis codes, you know, that to me as a provider and a loved one, you know, of mine that would be in that situation, that to me would be way more preferable. And, you know, but if they're home and have an NA and they have the resources, I'm checking on them every day, then maybe we want that Medicare choice, you know, all the choices that come with that. So I really think it's not a one and done answer. It's really got to be looked at through, do these people have advocates? Do they have resources? Do they understand how to navigate the system? Do they understand their own illnesses? And do they have education on what that looks like? Because you don't get a lot of that anymore in a 10-minute visit with a specialist. They send a piece of paper home, and not everybody takes the time to read through all the symptoms of changing status of your heart failure or your renal failure or your diabetes. So it's a very long-winded answer, which is my MO, I guess, but I think it's really important to think it through. It's just not simple.
Okay, at this point, what I had promised I would do and what I would like to do, I'm looking at the chat, looks like another question came in. A couple of questions came in. Let me look at those real quick, and then we'll go to opening it up for just conversation. The benefit of advanced practice practitioners in the nursing home and other settings with patients with multiple organ failures is evident. Unfortunately, Medicare doesn't want to pay for this for years. Okay, and Wayne, I may ask you to comment on this. This is your comment if you want to elaborate.
Well, I worked teaching geriatrics in family medicine residency for most of my career with a nurse practitioner. We went over as a team weekly with our residents, you know, and saw patients. So clearly that was much better than the traditional model where actually somebody may have seen them once a month. So I can see the Medicare Advantage. The difficulty is when you're working in a system, it's really hard to look at the whole overall picture. What CMS is trying to get at is they're trying to generalize, well, you know, emphasizing value over fee for service, which I think is a good thing. They've just had a great deal of difficulty operationalizing that. So I'm, you know, as a now current Medicare Advantage recipient, I'm very much in, putting money into that system. What I questioned my previous question was, I see these Medicare Advantage plans being kind of expanded to the much healthier Medicare population. And I think we're spending a lot of money badly in that situation. The actual situation right now is whether you look at physicians and what people are now calling apps, which is nurse practitioners and physician's assistant primarily, there's just not enough people to do the work that needs to be done because these are such multi-organ failure patients out there that we're keeping alive. We're able to keep them alive longer by spending a lot more money and a lot more resources, but we don't want to bear or Medicare doesn't want to bear the cost of that. So anyhow, I think that's really comes down to the question. I have Medicare Advantage also, and it's okay for me. I think traditional Medicare would be just as good, or if not better. But the real question is whether that's the model that's, like you keep saying, that one size doesn't fit all. I agree that the Medicare Advantage plans, particularly these special needs plans that we were talking about, are particularly effective for that population.
Yeah, thank you. And Bridgette, Kim, you want to comment on what Wayne just mentioned?
On the access to NPs, which actually Kim could probably speak even more to. I know that is her thing is NPs and expanding the practice authority of NPs, because I do think that answers a lot too of the access issues. Especially since COVID, a lot of people said we're done with healthcare. And if I wasn't so early in my career, I can't say that I would have made the same decision. So that's going to enhance our access issues when we have fewer providers. I do know one of the issues as a nurse practitioner, and to be honest with you, I don't know if it's even the same anymore, but nurse practitioners were reimbursed at 80% of what physicians were reimbursed for the exact same services in most cases. We are seeing it, I know, again, this Medicare Advantage plans as a way to just hire our own and staff our own. So I manage a team of almost 30 nurse practitioners and 1 physician assistant now, so that we are assuming the care, assuming the primary care. And that is almost a way not to circumvent Medicare's, I guess, under reimbursement of NPs and PAs, but to say that we value the care that these providers bring, so we will just hire them as part of our plan. So when I see a member, I don't bill. We essentially create a zero bill for Medicare, but I don't bill in a fee for service aspect for my services. I can see this member every single day of the week, and I don't make any more money off of that. Sorry, it's crazy light. And that is where I do see, again, the added benefit of the Medicare Advantage plan, because we are driven by outcomes. We're not driven by reimbursement. And so I would rather see this patient every single day of the week if it means preventing a hospitalization, because as a Medicare Advantage plan, that saves me money. But it's also better for the patient versus seeing a healthy member, once a week just to drive reimbursement. So again, kind of circumventing that question, but I think, yes, you're right. Our Medicare was not, I don't know that Medicare's ever been 100% on board with NPs and PAs, at least as evidenced by their reimbursement practices. But I think Medicare Advantage plans have certainly seen the value, especially when it comes to access to care.
Kim, did you want to add anything?
Actually, I would love to pull from, I really do see Bridgette as a content expert for Medicare Advantage plans. And I know you're more institutional special needs, but do you know the variation in, like Martha's comment was, her husband has an Advantage plan, but has zero contact that I can tell from any care management. So no benefit for ongoing health supervision. So in those non-specialized plans, and where we met actually was before your current company, with the going into the home, they have the choice. They could have Medicare if they want to, but they choose Medicare Advantage. Going into the home at those cadences, are there general Medicare Advantage plans that just don't have that piece anymore? Or is it an opt-in? I don't know.
Yeah, and most don't. Instead, they incentivize the primary care providers or the specialist, and they offer different, incentive plans to them. And then I will say there are consulting groups, especially when it comes to the risk adjustment coding and whatnot, that they will go into the primary care providers' offices and say, train them on their Medicare Advantage patients, and say when they call because they have a new cough and you see that they haven't had their annual Medicare visit this year, you need to go ahead and flag them for a Medicare wellness visit, is what they'll call it, even though at that point it's not a wellness visit. So no, most Medicare Advantage plans that don't serve usually a high risk population do not have at least in-person kind of care coordination aspect of their plan.
They do have a
My experience.
telemedicine or a virtual component. I know that, and work in conjunction with some primary care offices and incentivize that relationship of bridging the gap of care. I know that, but I didn't know about the face-to-face.
Quick question, Bridgette. I'm going to read one other comment in the chat. When we're looking at the Medicare plans, and let me do this. Let me read the chat first. And this is from one of the members here. In my personal experience handling my mother in Medicare for 8 years and my own experience 10 years in Medicare Advantage, hands-on superior in the cost and the care it offered to me. And she's referring to Medicare Advantage here. I certainly became knowledgeable in the navigation of Medicare, but I found it dreadful, even with supplemental insurance compared with my own post-65 care. So just a comment there. And Mary Ellen, if you don't mind me identifying you, since you did in the chat, do you want to add a comment? Because you're currently muted.
Rob, I'm sorry I can't come on camera, but I forgot I logged in at the computer that the camera's not working this morning because I was late. But for me, my mother had no really serious illnesses. It was just a long end of life. For me, I have only a autoimmune or psoriatic arthritis, but it keeps me visiting several different specialists and lots of medication involved. And the year that I came into Medicare, the state switched to Medicare Advantage. And so I chose Medicare Advantage because it had to be better than Medicare. I was sure of it. Well, the second year when I went to the state meeting and I listened to all of the people who were on straight Medicare with Blue Cross supplemental, all of their complaints. And I sat there and I thought, this is just like what I went through with my mother. And Medicare Advantage just is so much simpler in the way that it operates. And I understand Medicare, but most people don't do that. They don't go through the hours and hours it takes to figure out how to navigate that system. And I just personally can't see, for the average person over 65 years old who is not seriously ill, I can't see how Medicare could be better in my own mind. That's just my personal opinion. I don't have any medical background or any of the understanding that you people have, but in my own mind, I just can't see why people are still on plain Medicare if they have the choice. It makes no sense to me. I know that it's supposed to take money from Medicare. I understand that, but otherwise I don't understand.
Either of you want to follow up on that?
I think Bridgette, you can speak to how how it's an alternative, like how Medicare pays it. Or
yeah, so it is. I mean, if it were done in the way that it should be done, it should be apples and apples. And the theory is that Medicare will give basically a prospective payment of what they think they would have spent on this member based on those diagnosis codes to the Medicare Advantage plan to manage their care. Now, I will say we are held accountable for spending that money on clinical needs. If we're spending, 40% of that money on clinical cost and 60% of that money on administrative costs, Medicare is going to reassess those payments. Now, I will pre-argue that it is sometimes easier to put things in the clinical bucket that maybe aren't clinical. So I mean, that case can be made as well. But we are responsible for ensuring that the majority of those payments from Medicare are put towards clinical outcomes and clinical care of our members.
And
Go ahead.
sorry about that. So that's like, I think it's Lucia said her plan sends an MP home every year for an accurate visit. That's the visit that we're talking about that assesses where you are, what are your diagnosis codes. Then it goes to Medicare would have paid this for that. They project. So that's why that visit is very detailed, and also to hold you to the standards of how you care for this patient for the rest of the year. So I just wanted to insert, because I don't know how much everybody understands about what we speak of with the metrics and how it all works, but it does make sense once you break it down.
Yeah, and I was going to say to Mr. Hill's point, if a nurse practitioner is coming to your house once a year and only once a year, they're not offering a lot of clinical value in that sense. So yes, I will be the first to argue that that visit is for the sole purpose of collecting the diagnoses so that the Medicare Advantage plan is paid based on those diagnoses. Now they're paid based on any code submitted by any provider, but to ensure that a fee-for-service provider is submitting a hypertensive heart disease ICD code as opposed to an essential hypertension, they're probably not. So that's where that annual visit comes in to make sure that the codes that risk adjust are being captured. But again, in the community setting, I don't know how well the Medicare Advantage plans do at actually improving clinical outcomes, because that's not going to happen in one visit a year, if we're being honest.
But if they put more, if they label you with more diagnoses, they get paid more annually for your care.
Correct.
That's where they've been criticized for using that as a method to upcode, so to speak. Just kind of, and you can argue it both ways depending on how that is actually used. But right now, that's what CMS is looking at, and they're looking at particular insurance companies for having overdone that and overcharged based on calling somebody uncontrolled hypertension if their blood pressure was 145 on the the day that the person visited.
No, absolutely. And I think it's on the Medicare Advantage plans also their responsibility to ensure that they're providing the care that they're being paid for. Right. So again, in an institutional setting where we're seeing these members weekly and biweekly and monthly, it is essential that we are capturing, and accurately so, every diagnosis, because we are providing a tremendous amount of care to these members. Now, in the community setting, if they see that NP once a year and you capture that they have hypertensive heart disease and diabetes and CKD and all of these things, but then they never see another provider the rest of the year, they're not accessing the services that CMS is paying the MA plan for. So in which case, I do think it should be on the burden of the Medicare Advantage plan to ensure that they're outreaching to provide the services, but then that goes back to health literacy and access to care.
Okay,
I'm
hang on a second, Chair. We've got one person in front of you, then we'll get your question.
okay.
So
okay.
Margaret, if you could go ahead first, please.
Yes, I want to say something about the long-term care, that it seems as though the Medicare Advantage is a second set of eyes on long-term care, and that people really should be able to get the care that they're paying for. My mother was in adult care homes and then in a nursing home the last couple of months of her life. And the long-term care facilities, the adult care home was supposed to have a nurse there all the time, permanent nurse, but they came and go, and there were periods where there was no nurse in the facility. This has nothing to do with insurance. This has to do with the way the long-term care is operated. And then she had visiting program from visiting doctors that Medicare paid for. So she had, on top of the nurse in the facility, she had someone visiting her. This was all paid for by traditional Medicare. And still we had problems. And then she was in what do you call it, hospice care, which is also a capitated program, and they would send somebody in once a week. But they were limited because they had what they could do, because they have to keep their relationship with the facility. So that was a problem. And then when she went to long-term care in a nursing home, we had to drop the visiting doctor or her primary care doctor, which was a visiting doctor service, because she became under the auspices of the doctor of the nursing home. But we still had hospice coming in at least once a week, sometimes more than that. So it seems to me that the problem is that these long-term care facilities aren't being adequately supervised. And I can give you an example about my mother not getting her medication on time in the adult care facility. My sister noticed on the billing that they weren't buying enough medication. So we went and had them do an inventory, and I was present, my husband was present at the inventory, and they were short on more than one medication. And they said they would have everything resolved by the end of the week. And my husband just coincidentally was going into Duke University to have a heart operation. So my husband is being a prep for the operation the next day, and my sister's calling me up, and she said they didn't get the medication in, and she called the doctor, and she called the pharmacy, and she was trying to get all this stuff to get all this medication in. So I said to her, Kathy, we've done everything we possibly can do. You've got to call the county and have them file a complaint. And it took months, and the complaint came back unsubstantiated. Now, all you need is the prescription, a calculator to figure out there wasn't enough medication to possibly do it. So then I sent a complaint to the state, and they came back and rejected it and said, we don't evaluate county social services. And they sent it back to me and told me to send it to somebody else in the state. And that social worker said, no, it definitely belongs to the people that we initially, the HAD. And they lost it. He sent it to them, the complaint, and the state lost it. So then I had to go to the North Carolina Disability Association, and they put a lawyer on it, and all of a sudden it was found, and they said they had to get permission from the county to retrain the social workers. Right, retrain the social workers into what is unsubstantiated and what is not. Okay, so then we're moving my mother from the adult care home to the nursing home because she was definitely terminal. She had pneumonia, and these were her last days. So we had to get the nursing notes from the adult care facility to the nursing home. And in there, it shows that they ran out of medication and they had to run to the doctor, to the pharmacist, because they're supposed to keep 7-day supply, and they ran out. So I went to the disability in North Carolina, and they said, file another complaint, we'll see how they handle it. And the complaint was filed through the North Carolina Disability Association. And then after my mother died in July, she died in June, in July, I find out, they called it unsubstantiated again. And we had the notes from the Adult Care Association, the adult care home, with their letterhead. And it was still called unsubstantiated. So this is the problem. It's not what insurance you've got. It's that these homes are not being supervised properly.
Well, I understood, and that what your situation, and you tell me if I'm right or wrong, could have happened under either plan. It was a matter of supervision at the long-term care facility.
Yes.
Which is a somewhat different subject, but it's certainly on the money here. Lucia, I know you had a question as well. You're muted, Lucia. You need to unmute yourself.
Sorry. I just wanted to comment about the fact that that visit from the annual visit, I'm healthy, so I don't go to the doctor much. But that visit from the nurse is much better than the visit that I get from my doctor. And my doctor is a very good one. He takes time with you, but he has constraints with time. This nurse comes in and she's, you know, she really talks to you. So a lot of other things may come out, and I don't have any issues. So that and I don't pay my Medicare Advantage. I have one of those 0 plans. So I feel very happy with what I get for $0.
Thank you.
And the very few times that I needed something, it was there.
Yeah.
You know.
I'm going to move on to the next question. We have a question, Sandra. I hope you don't mind my using your name. She said, congratulations, Sandra. You just qualified for Medicare. We're all very happy for you. I am celebrating having much better insurance than I've had in the past. We are now seeing the fear factor being promoted in the media about Social Security running short of cash by 2033. What can be done to shore up Medicare? A bunch of things, but all of them are political hot potatoes, which makes it difficult. And I don't want to go on about that, but I don't think you're going to see a collapse of Medicare, because that block of people that are served by Medicare are the most potent political voting bloc in the country. And I think Medicare is going to be maintained. What form it takes and how it's going to be maintained, I guess, is an open question, but I don't see Medicare or Social Security being trashed, because they're two of the most popular programs that we have, even though they are the S word. So anyway, Sandra, did you want to add anything to that? You're muted currently.
Yes, well, I'm muted now, and Kim and Bridget, please keep working. We need all the contributions we can get into the system.
Thank you, Sandra. I'm going to close it up unless anybody has comments. And I know everybody, I mean, I have 2 parents that went through long-term care, and everybody has a horror story. I mean, there's always all kinds of crazy stuff that happened. So anyway, I'll stop my comments there. I don't want to ramble on. I want to thank everybody for their patience. And if you want to put something in the chat, I'll pass it on to Kim or to Bridget and get back to you. I know it's 1:15 and we had planned this thing for about an hour, and I know Kim and Bridget probably have to get back to work. So anyway, thank you all very much.
I appreciate y'all having me here.
Thank you.
Yes, thank you for having me.
Thank you.